On today's episode, listen in as our editors define what natural medicines are and discuss the safety and efficacy of several natural medicines, including ashwagandha, berberine, and turmeric. They'll also discuss how to navigate discussions with patients about supplements, including tips for choosing a quality supplement.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, pharmacy technicians, physicians, and nurses. None of the speakers have anything to disclose. Now, let's start our discussion.
So to kick us off, Steve, we're talking about natural medicines highlights. So could you briefly just answer the question, what are natural medicines?
Sure, and it's a great question. So, natural medicines are a form of alternative or complementary medicine. And for today's discussion, we'll be talking about herbal supplements, which you may have heard also called botanicals. They come as tablets, capsules, powders, even teas, and they're among the most common type of dietary supplements used over the past few decades. Now, the term dietary supplements represents quite a broad category that falls underneath. They include products taken by mouth, of course, to supplement the diet, and could be things like vitamins, minerals, herbals, and botanicals, and even enzymes.
That's awesome. Thanks for that high-level overview. And I think another question we have is, why are we even talking about this today? And we have some really good stats to share. About 4 out of 5 adults in the US take a dietary supplement, and consumers spent over $12 billion on supplements in the year 2022. So supplement use is increasing, and we continue to get a lot of questions about this. So now let's dive into the details on 5 of the top searched natural medicines, as these tend to raise a lot of questions in practice. So today we'll be talking more about ashwagandha, berberine, coenzyme Q10, melatonin, and turmeric. So let's start with ashwagandha. So where does ashwagandha come from? It's an evergreen shrub that grows in areas of Asia and Africa. Ashwagandha is traditionally used as an adaptogen. These are natural substances, so herbs, roots, mushrooms, and they're thought to work on the body's stress response and support the ability to kind of adjust to stress. So let's talk about what conditions it's effective for. And there are actually 2 big categories. Ashwagandha is possibly effective for improving symptoms of anxiety or psychological stress, based on some small studies that suggest modest benefit. There are also some small studies in patients with insomnia that suggest ashwagandha may modestly reduce the time to fall asleep, increase total sleep time, and improve sleep quality when compared to placebo. But just point out that the doses for these uses vary widely in studies, and studies can't really be compared apples to apples. So for anxiety or stress, we see doses up to 1,000 milligrams daily for up to 12 weeks. And then for insomnia, the doses that were looked at were between 120 milligrams to 600 milligrams daily for 6 to 12 weeks. There is a long list of indications that ashwagandha has insufficient evidence for, and there's just really not enough evidence to say if it's helpful or harmful for many uses, such as ADHD, aging, athletic performance, asthma and COPD, diabetes, fibromyalgia, fertility, and many, many others. So when it comes to safety and side effects, orally, ashwagandha seems well tolerated at typical doses, may cause some drowsiness, and in larger doses, it can cause GI upset, nausea, and vomiting. There are limited safety data, and that was looking at doses up to 1,250 milligrams for up to 6 months of use. But we really want to reinforce safety concerns with this supplement. Severe liver injury has been reported even with low doses or short-term use. Symptom onset with those cases occurred within 5 to 180 days of starting ashwagandha. And in some cases, liver injury occurred after more than a year of use. So just tell patients to be aware of symptoms of liver damage, such as jaundice, weight loss, nausea, stomach pain, and then also advise patients with existing liver disease, such as hepatitis, to avoid this supplement altogether. And the good news in all of this is that in most cases, liver enzymes normalize within 1 to 5 months after stopping ashwagandha. Let's review some information here for ashwagandha. When it comes to pregnancy and lactation, pregnant patients might feel stressed or like they need sleep, but pregnant patients should avoid ashwagandha since it may have abortifacient effects, and recommend avoiding it in lactation. We just don't have a lot of evidence. Also, when it comes to pediatrics, listen for, parents asking about using this for their kids. And we don't want to use it at this time. We just don't have enough studies in kids to show it's safe. Also, interactions. So it only makes sense that if we have this supplement that can cause rare liver injury, we probably don't want to couple it with another hepatotoxic med. So I would avoid using ashwagandha for patients who are taking isoniazid, methotrexate, phenytoin, just anything that can potentially harm the liver and increase that risk of liver injury. There are also concerns with ashwagandha having immunostimulant effects, meaning it could decrease the effects of immunosuppressants or it could exacerbate autoimmune diseases. So just be really cautious with folks with autoimmune disorders such as multiple sclerosis or rheumatoid arthritis, or patients on those immunosuppressants such as biologics or tacrolimus. And then also caution with ashwagandha, it might have additive effects with thyroid hormones, and it might exacerbate hyperthyroidism. And then there's a chance it may increase risk of low blood sugars or low blood pressure. So if patients are also on other medications to lower their blood glucose or blood pressure, just be cautious with that as well. So maybe just a little bit more increased monitoring for patients with diabetes or hypertension. And then to just summarize with some pearls here with ashwagandha, just be sure to counsel patients to report any symptoms of liver damage, and they might present with the yellowing of the skin or jaundice, weight loss, maybe some nausea and stomach pain complaints. And also, we're going to want to have patients stop ashwagandha 2 weeks before surgery. And that's because it can cause drowsiness. It may have some sedative effects. So just to mitigate any concerns with surgery and anesthesia, we're just going to have patients stop this before. Also point to labels. So ashwagandha plant is also called winter cherry, and the ripened fruit winter cherry is used to treat some different things like arthritis or gout, or it's used in kidney and bladder conditions. But for ashwagandha that we're talking about today, we are actually looking at the root. So be sure to check the label for the root extract when using it for stress, anxiety, or insomnia. And then also, ashwagandha comes in a lot of combo products. So just a plug to always, check those labels. Some products combine it with black pepper extract or piperine, which in theory enhances the absorption of ashwagandha and may increase its effects. So with that wraps up a little bit on ashwagandha. Steve, thanks for watching questions during this portion. What questions do you have for me from the audience?
Yeah, a viewer asks, does ashwagandha help menopausal symptoms, even though it doesn't help with a lot of other things?
Oh, that's a good question, Steve, because folks with menopausal symptoms often have stress, anxiety, and insomnia. So there is a potential it could help with those. There is one study I see here where taking ashwagandha root 300 milligrams twice a day for 8 weeks may improve symptom severity by 24%. And they also reported improved quality of life and hot flashes, but that's only based on one small study. And, it might just be something that if somebody wants to try it for, a month or two and see if it's helpful, that might not be a bad idea. But we don't have a lot of data to say, yes, this is going to be effective. Thank you. Okay, I'm going to move us along to berberine, Steve, and I'm going to hand the reins over to you to talk a little bit about berberine.
Excellent. So as we move over to berberine, it actually comes from the barberry shrub known as Berberis vulgaris. And then in terms of the background, let's take a moment to ask, what is berberine? It's a yellow bitter alkaloid compound that you'll find naturally in certain plants like the barberry shrub or golden seal. But the majority of berberine actually comes from the roots or rhizomes. And berberine is a hot topic right now because some people have called it nature's Ozempic. And Sarah, you and I know GLP-1s like Ozempic are becoming very, very popular and are prone to shortages because of that. And this is what's interesting. Research in animals has shown that berberine increases GLP-1 secretion in our bodies. And we know that GLP-1 agonists treat diabetes by increasing insulin secretion to decrease glucose, but they also decrease stomach emptying to help us feel full. So with that news, I can see why patients may be asking about this supplement and turning to it, especially with all these shortages going on. But let's see what the evidence says. When it comes to diabetes, there is evidence showing berberine is possibly effective, believe it or not. Clinical studies have shown that adding berberine to lifestyle changes can moderately reduce blood glucose and A1C in people with type 2 diabetes. These A1C changes, though, they change from about 0.4 to 0.7%. And this is also seen when berberine is combined with other diabetes meds. I'm thinking things like metformin, right? And A1C labs were seen to decrease by 0.6 to 0.9% there as well. Now, I'm open to your thoughts, Sarah, but based on that, I would avoid recommending berberine on its own for diabetes. Berberine's evidence is positive, but we do know we have robust data for our actual prescription GLP-1 agonists, right? And our other diabetes meds on the market. So I could see this as being an option to add on to other diabetes meds instead, if that makes sense.
It does. And I would agree with that assessment as well. I don't think I would ever recommend using it on its own, just because we
Yeah.
don't have those long-term outcomes.
Yeah, not a solo candidate for sure. So berberine has another interesting use, Sarah, and it's hypertension, where it is also possibly effective. There's evidence that berberine, if you take it daily for 2 months, added with amlodipine, actually decreases blood pressure. Now, the extent we're talking about here is a systolic decrease of about 5 millimeters of mercury and just 2 millimeters for diastolic blood pressure. Now, at first, I thought that doesn't seem like a whole lot, but evidence suggests decreasing systolic blood pressure by 5 millimeters of mercury may decrease the risk of CV events like a heart attack by potentially 10%. So that was actually surprising to me. Now, keep in mind, though, we have no direct evidence that berberine prevents those kinds of CV outcomes, only that it lowers blood pressure. So until those studies occur, we can't make that direct claim. So on a related note, we also have hyperlipidemia, right? A lot of CV themes here, where berberine is also found to be possibly effective. Now, the berberine dosage I found most often used here in these studies was 500 milligrams twice daily, or some people used it 3 times a day at a dose ranging from 200 to 500 milligrams, and some took it up to 2 years. Now, the clinical studies I found suggest that berberine alone might be as effective as statins with lowering lipid labs, which is interesting. Compared to these lipid-lowering meds on their own, combining them with berberine decreases total cholesterol by 10 to 15 milligrams per deciliter, triglycerides up to 30, and LDL by up to 9. But again, this is in combination. So it's kind of like what we're talking about diabetes. I wouldn't want to use this solo. And one interesting nugget I found, though, is that these lab improvements may not be seen when taking berberine longer than 3 months. So there's some conflicting evidence here we need to think about. And probably we need to use that when we talk about patients when we're framing their expectations, right?
That's really interesting, I think, and a huge thing to point out that if the improvements don't last, it may not be worth recommending it. Interesting.
Absolutely, especially when we're thinking about the cost too. And then we also have interest in weight loss. And here's where things change. It's actually where we have insufficient evidence to recommend berberine for this indication. This is important, Sarah, because we all know that a lot of our GLP-1 agonists are getting new indications for weight loss, and some patients may be extrapolating from that they can use this quote nature's Ozempic for weight loss. Now, several small studies were analyzed and showed that berberine up to 1,500 milligrams daily for up to 2 years can reduce weight, but only by about 4.5 pounds, and a BMI decrease of about zero point 0.5. This is when it's compared with placebo, life changes, or no intervention. It could sound decent, but these results didn't require patients to be overweight or even obese to be included. So it's kind of hard to say that this is meant for the intended population here. So if we're treating obesity, I would pretty much advise against berberine until we have more evidence. And then there are some other uses I've found that people were interested in for berberine, but these also had insufficient evidence. These included things like AFib, heart failure, stroke, and even irritable bowel disease or viral hepatitis. The list really goes on and on. But the evidence for all these, like I said, is insufficient to really support them. We just don't have the studies. And with that in mind, let's talk about the safety that we should always think about with these supplements. The good news is that it's generally well tolerated, even if given topically, which I found to be an interesting route that some people used. The most common side effects I saw were mostly GI related, talking about things like diarrhea, nausea, or abdominal pain. What's interesting and concerning about berberine is that it does stimulate uterine contractions, or at least the evidence suggests that. And when we're talking about a pregnant patient, those uterine contractions could cause preterm birth. We definitely don't want that. So this makes berberine likely unsafe in pregnant patients. And if the pregnant patient is taking it, it may also lead to something called kernicterus in the baby after it's born. This is where bilirubin in the baby's blood can get so high to the point it becomes toxic and can actually cause nerve damage or brain damage, which can be fatal. And this is something we always looked out for in the NICU during my pastoral. Now, berberine also transfers through breast milk. So there is still that same kernicterus concern even after the baby's born and breastfeeding. So overall, I would just avoid berberine in pregnant and lactating patients based on that. And this flows well into our concerns with pediatrics. Based on that lack of breastfeeding safety evidence, we know that giving berberine directly to newborns is not a good idea, whether it's through breastfeeding or taking it directly. And we also don't have evidence to support its safety, even in older kids. So it's best to avoid giving this to children until we have more data. And with interactions, I was surprised to find out that there is actually quite a few. Evidence shows that it may increase levels metabolized by CYP2C9, 2D6, and even 3A4. So this makes me think of drugs that could raise levels like cyclosporine, warfarin, or even oral contraceptives. And we also have to think about the additive effects it can do to some of those indications we talked about earlier. It can actually increase the effects of antiplatelet meds, antihypertensives, diabetes meds, of course, and sedatives. So if I had a patient interested in berberine, Sarah, there are some other points I want to consider as well. We have to keep in mind dosage forms, right? Soft gel capsules for berberine have gelatin made from pork or even bovine or cow sources, right? So this may not align with some cultural or religious dietary beliefs that we should always think about. But it's also available in topical gels, ointments, and aromatherapy essential oils as an alternative if people wish to do that, although the evidence may not be there for those specific routes. I also found some products where berberine is combined with other ingredients like cinnamon. So looking at labels closely can help patients know what they're actually taking. Sarah, what questions do we have coming in for me?
Okay, it looks like there's one here about interactions as well. So let's talk a little bit about interactions. Are there any drug interactions with SSRIs? So, what do we know about that to answer this audience question?
That's a great question because SSRIs, as we know, are so common, and we do need to think about this combination. Now, we know that berberine inhibits 3A4, 2C9, and 2D6, but we don't have that direct evidence saying there's interactions between like actual SSRIs and berberine. But we can think about and extrapolate from that evidence. I would think about SSRIs that are metabolized through those enzymes specifically. Otherwise, they could increase those SSRI levels to toxic amounts and lead to things like serotonin syndrome. So based on those classes of CYP enzymes, I would probably avoid SSRI options like fluoxetine, sertraline, or paroxetine, since they go through those. But when I think about this too, venlafaxine, citalopram, and mirtazapine don't go through those or go through those less. So those may be better options to choose from if you need to.
So, what is coenzyme Q10? Well, it's naturally found in the body with the highest concentrations in the mitochondria of certain organ cells like the heart, liver, kidney, and pancreas. And it acts like an antioxidant, neutralizing free radicals that can cause cell damage. And it also is touted to improve energy levels and help augment the immune system. And you also may hear coenzyme Q10 go by some other names, such as ubiquinone or ubiquinol. And so just to be aware of that, if patients ask for one of those, it's considered one of the physiologic forms of coenzyme Q10. So let's start with where coenzyme Q10 is likely effective. So there are two rare conditions where patients may have symptomatic coenzyme Q10 deficiency, and this can be genetic or acquired due to different medications or conditions. And then also it can be used to reduce symptoms of mitochondrial muscle disease, and that can also be genetic or acquired. But these are just very rare indications where it is effective. And then there are some areas where coenzyme Q10 is possibly effective, and a few that I want to mention today where you may have had questions about in practice are congestive heart failure, but that is when it is added to standard heart failure medications and may improve fatigue, sleep, and tender points and pain in patients with fibromyalgia. And then lastly, I want to mention that coenzyme Q10, 100 milligrams to 150 milligrams a day, may actually help prevent migraine headaches. So it won't treat them, but it may help prevent them. Just note it may take up to 3 months to see any benefit. So if somebody's wanting to try coenzyme Q10 for migraines, just encourage them to try it for at least 3 months. And actually, the American Academy of Neurology considers this as possibly effective for migraine prevention in adults. And then, like the other supplements we're talking about today, there's a long, long list of things that's been studied for. But coenzyme Q10 is possibly ineffective for conditions like Parkinson's disease or Alzheimer's. So we generally wouldn't want to advise patients to take it for those indications. And it's also likely ineffective for athletic performance, meaning there's no evidence it's beneficial to use this supplement. And then there's also interest in a lot of other uses: angina, chronic fatigue syndrome, hypertension. But there's just really not enough evidence to say it's helpful for these or other conditions. Statins like atorvastatin or simvastatin can lower coenzyme Q10 levels in the blood and muscle tissue, and it's thought that this can lead to issues like muscle pain or weakness. But evidence on whether coenzyme Q10 helps is actually conflicting. Some individual studies suggest a modest benefit, but when looking at a meta-analysis where we put those results of these several small studies together, it suggests there are no improvement on muscle pain or statin tolerability. And those doses that have been studied range from 100 milligrams to 600 milligrams a day for 1 to 3 months. So I think it's important that we talk about the safety now that we know that it may or may not be effective. So let's review some safety information. We can clarify that orally, coenzyme Q10 is generally well tolerated. So like many other supplements, the most common side effects are GI related. So diarrhea is probably the most common. And one way to minimize it with this supplement is by dividing doses. But I had mentioned previously, you can see doses up to 600 milligrams a day. So we're definitely going to want to divide those doses to limit the GI side effects if needed. And then if asked about using coenzyme Q10 during pregnancy, this is one supplement that's possibly safe when taken orally, but this is based on very limited evidence. Taking 100 milligrams twice daily, starting at 20 weeks gestation and taken until term. But the same doesn't hold true for breastfeeding patients. There's just not enough evidence to say whether coenzyme Q10 is safe during lactation. And then also in children, if you're asked about coenzyme Q10 in kids, you can explain it's possibly safe when taken orally based on limited studies down to 2 months of age. And this is using 1 to 10 milligrams per kilogram per day for up to 9 months. And keep in mind, though, that this is likely for those patients found to have deficiencies, since those rare disorders I mentioned where this is likely effective are often diagnosed in childhood. We want to let patients know that coenzyme Q10 doesn't have any major drug interactions, but it's still prudent to add this supplement to patient profiles just in case. I do want to point out a few things. Some research shows that coenzyme Q10 can lower blood pressure, but other studies have shown conflicting results. So it's just one of those things where you're just going to want to have patients report any lower blood pressure, signs of dizziness. And then, Steve, I also want to point out that coenzyme Q10 is structurally similar to vitamin K or menaquinone. And this actually helps promote blood clotting. So, advise caution in patients taking warfarin, since coenzyme Q10 might decrease its effects. So patients may need some more frequent monitoring. So it's just important to note that coenzyme Q10, even though it's well tolerated, doesn't have a lot of interactions, it's structurally similar to that vitamin K. So something to keep in the back of your mind.
That's a really good point.
And as I shared earlier, coenzyme Q10 comes in two forms, ubiquinol and ubiquinone. However, there is no advantage of one form over the other. And because coenzyme Q10 comes in a gel or a soft gel capsule form, it may contain gelatin. So some patients may wish to avoid it due to allergies or lifestyles. So just keep that in mind with this capsule. And if this is the case, you may find some alternative coenzyme Q10 products made with cellulose instead. And since coenzyme Q10 is a fat soluble vitamin, it may be helpful if patients take it with fat containing foods to help boost that absorption. All right, so that wraps up the presentation portion. Steve, did you get any good audience questions about coenzyme Q10?
Yeah, we did. We actually have one here about infertility. An audience member is asking, what role does CoQ10 play in infertility?
Great question. Infertility falls into the long list of indications where we don't have enough reliable evidence to recommend it. It looks like there are a few small studies in infertile women where coenzyme Q10 may increase the odds of pregnancy, but it doesn't seem to impact the rate of live births. So there's also some information in males where coenzyme Q10 may improve sperm function. But once again, when you're looking at long-term efficacy, there's no good evidence that it increases pregnancy rates.
Yeah, loving these audience questions, Sarah. Now, flipping gears, what about melatonin? Pretty popular among our patients, right? I've even
Mhm.
taken melatonin in the past when I've had sleeping issues, right? And that's what most of us think of melatonin as being used for, sleep. But I found there's also interest in using it for other things like ADHD, migraines, and others that we'll talk about. And I've gotten so many questions about dosing or interactions in my career, even as a role as a pediatric pharmacist in a hospital. So I think we all encounter these from time to time. So let's see what we need to consider. Now, I could see why many think of melatonin as safe and being a natural medicine since it's a hormone made in our bodies. It's produced in the brain by the pineal gland to regulate our circadian rhythm that helps regulate our sleep patterns. And people with trouble sleeping may have low melatonin levels. In fact, it is likely effective for specific sleep disorders. This includes delayed sleep phase syndrome. This is where a person's bedtime is delayed by 2 or more hours beyond the usual bedtime. As an example that I could think of, the patient might not be able to fall asleep until 4 a.m. and then find it hard to wake up until the afternoon. Obviously, that can disrupt things like work, social activities, and things like that. And studies have used 5 milligrams nightly in adults and up to 6 milligrams in kids for this. For adults, it was used up to about 9 months, whereas for kids, it was used for just 1 month, which to me is pretty short. And evidence also suggests it's likely effective in some patients with a condition called non 24-hour sleep wake disorder. Now, I wasn't completely familiar with this. So when I looked it up, this is something that can particularly affect blind patients. They find their bedtime gradually getting pushed back farther and farther every day from minutes to even hours. And then this gets them out of sync with that usual 24-hour circadian rhythm. And the doses used here were up to 4 milligrams nightly in kids and 10 milligrams in adults, with durations up to about 6 years, which is a pretty long time. Then that brings the question of what about for insomnia? Because what we just looked at were for specific sleep disorders. And insomnia we know is pretty common. Now, I was surprised to find out that it does shorten time to fall asleep, but the time frame that was studied, it only showed about 7 to 12 minutes difference. Some folks could argue that's not a whole lot of time, especially if you're someone lying awake at night for hours, right? But each case may be different, so it kind of depends on the benefit there. Similarly, total sleep time when using melatonin for insomnia might only be increased by 8 minutes, which again doesn't sound like a whole lot, and the data here is unclear. And then that question I always get, what about dosing? So, if adult patients want to take melatonin for insomnia, suggest starting with a dose of up to 3 milligrams or up to 1 milligram in kids. And these should be taken 30 to 60 minutes before bed to give it enough time to absorb and to act. Then recommend adjusting that dose up or down based on the patient's response and side effects. And keep in mind that most adults won't need over 6 milligrams per day or over 3 milligrams per day in kids. So hopefully that kind of explains it and sets up kind of a nice frame of mind when we're starting and adjusting these doses. Now on to some of our possibly effective indications here. It's actually possibly effective for many other conditions. One that sticks out to me is jet lag during maybe a vacation or a trip. It could help with alertness and reduce daytime sleepiness and tiredness, but it is conflicting whether it helps decrease the time to fall asleep like we saw with insomnia. Now, it may also be possibly effective for migraine prophylaxis. Taking before bed for up to 6 months can prevent migraine headaches and maybe even decrease the need for taking pain meds for it. Now, what's interesting is that it's not clear if melatonin helps for migraine. The studies didn't compare melatonin to a placebo or another treatment to really have a fair comparison. So it's hard to say at this time for treatment whether it's effective. And then there are several indications where we have lack of effectiveness, where it doesn't seem to improve sleeping problems in patients, for example, those who do shift work. And there's interest in melatonin for many other uses, such as ADHD or to prevent delirium, even in hospitalized patients. But again, we don't have enough evidence whether to say it's actually helpful for these instances, and I would be very hard pressed to have to recommend these in those scenarios. Now, I've gotten many questions about melatonin safety from patients and prescribers. So, thankfully, oral melatonin is generally well tolerated. Side effects to focus on would be things like drowsiness or dizziness, and even headache or nausea. And short term use is likely safe in adults based on evidence using up to 8 milligrams per day for up to 6 months, and possibly safe for up to 2 years in some patients. And thankfully, dependence has not been found. But we should advise against taking melatonin in pregnancy or lactation. What's interesting here is there's evidence that high doses, now we're talking a whopping like 75 to 300 milligrams daily, might inhibit ovulation and impair pregnancy. And there's not enough evidence to say whether it's safe during pregnancy at lower doses or with breastfeeding. So we can't really make a safe recommendation there. But what about for pediatrics? In fact, short term use is possibly safe. Studies we found in children have been limited in duration, such as up to only 4 weeks, so a pretty short amount of time. And what's important here is there's some concern that taking melatonin might adversely affect gonadal development in kids, so reproductive development, but the data is limited and unclear. So recommend parents only intentionally give melatonin to their kids if there's a real medical reason to do so. I would say that healthy kids shouldn't be taking melatonin on a regular basis to fall asleep. And we need to think about other risks here too. Although rare, pediatric overdoses of melatonin have occurred and they've resulted in hospitalization, needing mechanical ventilation, and even death. So, in fact, we found that 11,000 emergency department visits occurred between 2019 and 2022 alone. So, some of the formulations are colorful gummies, and I can see how they look like enticing candy to kids. To me, I would recommend parents choose a product with a child resistant cap and counsel patients secure meds outside of children's reach, just like we do with all meds, and even with supplements. Now, if patients want to take melatonin, we should also ask about current meds and think about interactions, right? There are some situations where I would be more cautious. One example is patients on anti-seizure meds or meds that lower the seizure threshold. I'm thinking things like bupropion, for example. Some research suggests melatonin might increase seizure risk in certain patients, especially children. And melatonin might also stimulate immune function. And then, since melatonin has sedating effects, that's what we're using it for, right? It can have additive effects with other CNS depressants, things like opioids or benzodiazepines, and can increase drowsiness, dizziness, and sleepiness. Melatonin also inhibits CYP1A2 and 2C19, so it may increase the level of drugs that go through those pathways. All that said, I do have some practice pearls that we can share, Sarah. First, we can all help patients look for possible causes of insomnia before thinking about moving to melatonin to treat it. So, for example, meds such as stimulants for ADHD or some SSRIs can impact sleep. And underlying conditions may also be contributing to insomnia that we should account for. Thinking about things like pain or depression or even restless leg syndrome and even heartburn, when you think about it, can worsen insomnia. So we should be thinking about the source of that sleeplessness. And we can help emphasize sleep hygiene, things like doing relaxation exercises or avoiding bright lights from a TV or a phone right before bed. And then, if you are moving to melatonin products, help your patients sort through them. Try to recommend one that's immediate release. There's not much evidence for delayed or timed release formulations for some of our sleep issues that we talked about earlier. Also, it would be good to be aware that melatonin comes in different dosage forms like tabs or gummies, and some are labeled in micrograms instead of milligrams, and making sure we don't confuse those. So double check those strengths and units to make sure patients get the right item. And you might get questions where the melatonin is made. Most are synthetic, so made in a lab, but some products are sourced from actual animal pineal glands, believe it or not. I was kind of surprised to hear that. So you may have some patients that don't want it sourced that way, and to consider that. And then, regardless of why a patient is using melatonin, remind them not to drive or operate, heavy machinery for up to 4 or 5 hours after taking melatonin because of that potential for causing daytime sleepiness. Ooh, so that was a lot about melatonin. So, Sarah, what kind of audience member questions do we have on that? I'm sure we had many.
Yes, we have an audience member asking, does taking melatonin inhibit the body's own melatonin production?
With some meds, thinking of things like opioids and benzodiazepines like lorazepam, we do worry that patients will not be able to produce or transmit those neurotransmitters like they did before the med, right? And we know this can set the stage for things like withdrawal when the med is stopped. And that's a common issue with many sleep meds. What's interesting here is that giving melatonin doesn't seem to decrease endogenous melatonin production. So withdrawal symptoms like rebound insomnia haven't been reported when it's stopped. And this also makes me think about Ramelteon, the prescription melatonin analog on the market. It also doesn't report having withdrawal effects either, and it's not a controlled substance. So, pretty interesting.
Very interesting. Good points. Let's switch gears now and take a closer look at turmeric, which continues to be one of the top selling herbal supplements. So many people often think of turmeric as safe since it's a spice and it's in many of our spice cabinets. It's derived from the root of the turmeric plant, which is a member of the ginger family. Curcumin is the yellow colored primary active constituent derived from turmeric, and it's also commonly used to color foods and cosmetics. Also, curcumin seems to have anti-inflammatory and antioxidant effects, which leads us to the interest for using it for a variety of conditions. So let's talk about some areas where turmeric is possibly effective. There are some small clinical studies showing benefit in patients with functional dyspepsia. There are also some data that suggests turmeric may improve symptoms of knee arthritis, such as knee pain and stiffness. And we'll talk about these two indications in a little bit more depth in a minute. And then there's also some evidence that suggests oral curcumin seems to attenuate fat deposition and improve some metabolic parameters such as liver enzymes, hemoglobin A1C, and total cholesterol in adults with non-alcoholic fatty liver disease, or what is now being called metabolic dysfunction-associated steatotic liver disease. So let's hone in on its use in functional dyspepsia or indigestion, since we see this commonly in practice. And this is sometimes called non-ulcer dyspepsia, since these patients don't have an ulcer. And these patients may have stomach pain or bloating after eating or heartburn symptoms. And we have some evidence that shows that oral curcumin is similarly effective when compared with the proton pump inhibitor omeprazole. But turmeric might not provide further symptom reduction in patients also taking famotidine or omeprazole. So, if patients want to take turmeric for dyspepsia, suggest trying 500 milligrams 4 times a day of the curcumin constituent. And most studies were short-term using it for this indication, lasting from 7 to 30 days. And I think I've had more questions about using turmeric for arthritis, even from some friends and family members. So let's look at the evidence here. Several meta-analyses show that turmeric may reduce knee pain and stiffness, may improve physical function, and even reduce the need for rescue medicines when compared to placebo. However, those benefits were reduced in patients as age increased and also as body mass index increased. And these studies used a variety of products and doses. They weren't the best quality evidence, so it just really makes it hard to draw great conclusions. It's also unclear how turmeric compares to NSAIDs or other meds that we may use for osteoarthritis. There aren't any good comparative studies out there. And not all turmeric products studied seem to be effective for improving symptoms of osteoarthritis. So we really have some mixed evidence there. Some doses included a turmeric extract of 500 milligrams 3 to 4 times daily for 4 to 6 weeks, or turmeric extract 500 milligrams twice daily for 3 months. In general, turmeric extract has most often been used in doses of 1.5 grams daily for up to 3 months, but just know there's no best dose for osteoarthritis. On the other hand, turmeric does not seem to improve the healing of peptic or gastric ulcers when compared to placebo, and turmeric doesn't seem to improve cognitive function or slow cognitive decline in patients with Alzheimer's disease. There's interest in turmeric for many, many other uses, such as diabetes, irritable bowel syndrome, ulcerative colitis, but there's really just not enough evidence to say whether it's helpful for these conditions. So that's just a quick overview of efficacy. Let's move on to safety. We can clarify that oral turmeric is generally well tolerated when used short term. Products providing up to 8 grams of curcumin have been safely used for up to 2 months. So that's good. And caution patients about the GI side effects, like all of these supplements. Diarrhea or nausea are the most common side effects. But also caution that at least 70 reports of liver damage are linked with turmeric, especially at high doses or with highly bioavailable formulations, such as those containing black pepper extract or piperine. And some of these cases occurred after 2 weeks, others up to 14 months of use. And sometimes turmeric was used with other supplements and medications. And most cases of liver damage resolved upon discontinuation of the supplement. And be aware for patients who are pregnant or lactating, turmeric in usual amounts in food is likely safe in pregnancy and lactation. So if you're just using it as a regular spice, it is fine. But advise against medicinal doses of turmeric in pregnancy. It might stimulate the uterus. And there's also not enough evidence to say if medicinal amounts are safe in lactation. And then when looking at pediatrics, research with turmeric is limited, and we should really not be using this in kids either. There are no known major interactions with turmeric, but there are some situations in which we need to be more cautious. So if a patient wants to take turmeric, we should ask about current meds and make sure we're updating those med lists. So for example, advise caution in patients on antithrombotic meds. Some research suggests turmeric may have antiplatelet effects, and so there might be an increased risk of bleeding. And since we have rare case reports of liver damage, we'd want to avoid turmeric in patients who already have liver disease, such as hepatitis, and then caution against using turmeric with those known hepatotoxic meds like isoniazid or methotrexate, since this could increase the risk of liver injury. And also be aware that turmeric might increase levels of drugs metabolized by different cytochrome P450 enzymes. For example, we'd want to watch for meds such as duloxetine, apixaban, and substrates of P-glycoprotein, such as rivaroxaban. We just really want to be cautious. This is mostly in vitro and animal research. So there is one case report of a transplant patient with acute kidney toxicity and elevated tacrolimus levels after 10 days of turmeric powder consumption. But this was at a dose of 15 or more spoonfuls a day. So it was a very large amount that led to the possible drug interaction. So just be aware that it's mostly in vitro and animal, but the risk is still there.
Yeah, that's a huge amount. Very interesting.
Okay. So a few practice pearls, and thinking of safety first, we want to ensure patients report any symptoms of liver damage. So if they have any stomach pain, nausea, weight loss, yellowing of the skin, be sure to report that right away. And since there are so many products out there and not necessarily a standard formulation of turmeric, point patients to the supplement facts to check on the amount in each product. And it may be labeled as curcumin complex, curcumin, curcuminoids, can be labeled as a lot of different things. And also be aware that some turmeric supplements claim to boost absorption. And so they might be labeled as having liposomal or nanoparticle formulations, or adding that piperine or black pepper extract I mentioned earlier to boost that absorption. So just point patients to labels to see what they're really getting with turmeric products. And then also advise that there's no good evidence that any one product works best. Special forms are often more costly as well. So Steve, before we get into audience questions, time for a fun fact. Did you know a typical dose of 1 to 2 grams a day of turmeric extract works out to be about 5 to 10 teaspoonfuls of turmeric spice?
Yikes, that sounds like a lot.
So it would be really tough to get these doses from the spice itself. So are there any questions about turmeric we should chat about today?
That's a really vibrant color. One listener asks, can turmeric dye skin or eyes or even teeth?
And that was a great question. We had to look into that a little bit. But yellow discoloration of the skin has been reported rarely. There are some reports of temporary yellow skin discoloration. There's also a report of someone who drank 3 to 4 glasses of soaked fresh turmeric root and powder, and they had yellow skin pigmentation. It slightly improved after about 4 weeks. So yeah, there are some cases out there. There's a possibility it might even impact some dental restoration. So depending on what the dentist is using, it could even stain some teeth. So that's interesting too. So, Steve, I was wondering if you could help me discuss how we can help navigate discussions with patients on choosing a product.
Absolutely. Happy to help with that. Now, many patients we know use natural medicines or supplements, but they don't want to share this info with us for a variety of reasons. However, as we discussed today, there are potential interactions, safety concerns, side effects with supplements we need to think about. So it's best to directly ask the patient at every encounter. And I would document these in the patient's profile in the pharmacy and the EHR. I would be sure to ask open ended questions that begin with why, how, what to allow the patient to respond. And that'd be based on their experience and their understanding. And I think it's important about having an open mind here. That can help open the door to honest communication with our patients. And I think that can lead to shared decision making and a discussion about those risks and benefits of using those supplements.
Excellent. Super helpful as we do tend to get a lot of these questions in practice. So that's great
Absolutely.
information. So it's really important to explain to patients that most alternative therapies are not regulated by the US Food and Drug Administration or FDA, or in Canada by Health Canada as strictly as conventional medicine is. And unfortunately, there have been a number of high profile events over the past 2 decades that have really raised concerns about the quality of supplements on the market. And the main concerns relate to whether the labels accurately list the ingredients in the product and ingredient quantities. And then we also get really worried about unwanted drugs or contaminants in the product. So, we want to continue to educate patients that natural does not necessarily mean risk free. For example, there are reports of some turmeric sources being contaminated with lead. That's an example of one of the supplements we talked about today. And then we want to guide patients towards products that are certified by a reputable third party if possible to help ensure they get a quality product and it has labeled ingredients and doesn't have harmful levels of contaminants. And there have been a lot of reports lately of different things being recalled because they are finding different ingredients in these products. And one that came to mind was undeclared ingredients for berberine products and other supplements touted for weight loss. There's other different contaminants in there. And sometimes it's even other, prescription medications. But Steve, do you have anything to comment here on?
Yeah, it's unfortunate and scary that some of those products are on the market, but I think we're the best suited professional to help guide our patients through that. So, talking about selected quality certifications, like you mentioned, there have been efforts to demonstrate that commitment to quality. So, some manufacturers have chosen to pursue those third party certifications you talked about. There are currently a number of different ones that offer that program for supplement manufacturers, and you may see some of these logos on supplement bottles. The details of each of these programs, though, as well as their ability to truly confirm product quality, can vary. So, knowing the ins and outs of those are important. One example is the USP verified product. These are tested and have verified ingredients, potency, and manufacturing processes, and they've even tested for those contaminants. So, looking for these certifications can help us guide our patients to a safe product.
Awesome. Thank you for reviewing that.
We hope you enjoyed and gained practical insights from listening into this discussion. Now that you've listened, pharmacists, pharmacy technicians, physicians, and nurses can receive CE credit.